Okay, welcome everybody to this month's edition of MI Med Stories. This is part of the MI Med group that we've had for a number of years. Stephen Cole, who's with us today, is kind of the founder and kind of spearheads this. And we really look forward to this, our stories where we bring people that are doing, work in the MI motivational interviewing ecospace to share their work. And today we have Mead Eagleston. So I'm just going to let Stephen just share about MI Meds and then we can get started.
All right, very briefly, thank you for being here. So, as you heard, I'm Stephen Cole, and shortly after I joined Mint, I started organizing meetings of people who were interested in talking to each other. So, we're an informal group, and I'm founding and trying to keep things together, mostly because people come in and out. And at some point, MIMed may become more formalized, and there'll be a formal structure of leadership. In the meantime, I thank Michael for pulling us together. And it's a group of people in Mint, but we're dedicated to being beyond Mint as well, because there's so many people in healthcare who are interested in teaching and using MI. And so we meet every other month with MI Med Stories, and we meet the other months with an ad hoc group. And so I invite you to join our meetings on the ad hoc group because that's where we develop and hopefully formalize and become more structured and develop products of enduring value. So I'm going to stop talking and turn it back to Michael and Mead, and thank you all for coming. This group has been growing with the kind of energy that Michael has been putting into it and marketing. So it's great to see everybody.
Thanks, Stephen. So I'm going to introduce Dr. Mead Eagleston, has worked as a therapist and program manager in addiction treatment settings, community health programs, and the VA health system. In 2024, she moved to, I guess, where she is now, Lewis Gale Physicians Group, where she practices, outpatient addiction treatment. And she provides, training and counseling services in the motivational interviewing and addiction treatment area. She has her PhD from The Ohio State. She did her postdoc training at Durham VA in North Carolina. So, Mead, I'm going to pass it to you and let you get started. Thank you for joining us.
Hi, welcome. And just I guess to clarify my position, which will also contribute to our goals today as a meeting, I'm the psychology faculty person for the psychiatric residency for this hospital. And what that means on the ground, because titles don't always describe the work, is I focus on training the psychiatric residents in psychotherapy. And a part of that is training them on motivational interviewing. And I, as Michael said, I'm a member of the Motivational Interviewing Network of Trainers, MINT. And every year, MINT has a meeting. And this year at our meeting, people involved in training MI in healthcare settings got together and we had a discussion about what a variety of things, but looking at our experiences, the models of training that we were using, some of our hopes and goals within those settings regarding motivational interviewing. And the goal today is to do much of the same. So when Michael and Steve asked me to come to do this today, the idea was to facilitate discussion. At the meeting at Mint, I didn't actually talk a ton. I did a lot of listening and summarizing and using my best listening skills. So I hope to do that today. I'm happy also to share my own experience in this. But I would love to start the discussion hearing a little bit about what you are doing with medical staff in healthcare settings regarding regarding motivational interviewing.
I'm glad to jump in. I have been teaching motivational interviewing since 1983. So I was teaching for about 6 years before the first Mint occurred, and most of that has been in medical settings. And I have traveled across the United States, mostly providing training for medical professionals. I trained for a number of years the Nurse Family Partnership Program, which are nurses that make home visits, a lot of substance abuse professionals. Currently, I train in the Andrew Weil Center for Integrative Medicine in Tucson, Arizona. I used to be located in Tucson, now I'm in Colorado. And I'm glad to bring that up because look at my white hair. I'm getting old. And at some point they're going to figure out I am old. And somebody's going to have to replace me. And this is a group that is one of the most wonderful groups to teach. These are fellows, people, physicians who are already graduated, already in practice. They know their patients don't follow their good advice, and they're looking for ways to help those patients, and they've chosen to get into this fellowship, which is 3 years long, so it's online except for 3 times across the 3 years. They come into Tucson for 1 week, and various people get to talk to them. I get to talk to them each year. So I get to talk to each class 3 times. So over 3 years, I get 4.5 hours to talk to these fellows about motivational interviewing, which they consistently say is the most valuable part of their fellowship. I don't believe that's because of me, although I play lots of fun videos. But at some point, somebody else is going to have to do this because I hate to travel. And it used to be I would, go 5 miles from my home up to where the fellowship was happening at a hotel. Now I have to fly. And this is a wonderful group to work with. They have selected into integrative medicine because they want to collaborate with their patients. They want to value the expertise that their patients have. So it is really great. So over the next year or so, if you think you can see yourself traveling to Tucson 6 times a year, so it's September, October, November, January, February, March. So pretty good time to be in Tucson. September and March are going to be hot, but the other times, 70 degrees. So a lot of you that are in cold areas right now, if you went to Tucson, it would be a brutal 70 degrees. So anyway, it's a wonderful opportunity, and it's going to come up sometime in the next year or two because I'm old. Thank you.
And that I'll add is very similar, kind of what you're talking about. One, that there's not always someone with strong expertise embedded into the healthcare setting, so they bring people in, and also that you get this contact over time that's fairly brief, and people are supposed to learn motivational interviewing from that. I'm curious, what kind of, during the 4.5 hour trainings that you do, what sort of activities do you do? It sounds like video. It sounds like it's didactic primarily. Okay.
So they have online modules. So I'm not the only exposure they have to MI, but they have like a module that's maybe 5-6 hours long where they're given some instruction. They have to complete some exercises. 2 times during their 3 years, they have to submit a example of change talk and sustained talk that they've heard from a client. They have to identify that. They have to submit either what they said at the time or what they can think of saying now. I read that. I give them written feedback on, yes, you got it. Oh, you missed this. Here's what I might have said. So that happens 2 times a year. There's a couple of fellows who will submit a now with AI in particular, they will submit a fairly long transcript, so maybe a 10-minute transcript of their interaction with a patient, and maybe 2, 3 times a fellow will send me an audio recording of their interaction with a patient, and I will give them feedback on that. So, of course, in the hour and a half that I have on any year, there's some didactic. So initially, it's presenting motivational interviewing as a contrast to what they're most familiar with, which is a directing helping style. That is overwhelmingly what they've seen, heard, practiced. So motivational interviewing helping style is presented as an alternative to that. Then the idea of change talk, being able to hear change talk, respond to it. And then the final year, I focus on affirmations. So those are the didactic kind of components within that hour and a half. In a small group dyad exercises where they might try out some of these things.
Thanks for sharing that, Robert. I wonder what other people's experiences, like what in terms of your structure and population are you doing with the medical staff training?
I can offer, and so we have a few students who are working with me, right? So I can actually speak for some of the work that they're at least beginning to do. We train in our family medicine residency clinic, and obviously we teach lots of behavioral medicine content in general, but our primary focus actually is in those interpersonal skills that are captured by motivational interviewing. So we really actually sit down and work on a number of iterations of role plays, and we're seeking to get to increased proficiency. So, a lot of coding and use of those kinds of rubrics to help us to get concrete about what MI looks like in conversations, and how to look at one's own, skill sets in a relevant way.
How much time do you get with the family medicine residents over the year?
Well, so we have a rotation with each PGY1, and in that window of time, we have I think about 4 half days to cover everything behavioral medicine. But that is enough time for us to work on some of these MI iterations and exposure content, and we do an annual workshop as well with them. Okay. But in the PGY 2 and 3 years, we have a lot less exposure to them. So we have an encounter we call a real-time consultation that primarily focuses on sort of consulting with their own patient encounter. So you can see that would just be really like the whole gamut of behavioral medicine. But then we practice some of the more difficult conversations in terms of role plays, because those don't always present, using some MI structure. And for those same folks in the PGY 2s and 3 years, we do a booster session, which again involves that sort of 3 iterations of real plays where the feedback is given according to the mighty, and we try again.
Okay. So you integrate, you have the sort of 4 half days going through PGY1, which is nice because you get folks before they've gone through sort of the full development and fostering of that more directive style. And then you get a chance to also, again, code and provide some coaching over the course of the next couple of years as well.
Yeah, those are smatterings, admittedly, like twice one of those each per resident in their whole PGY 2 and 3 years. But yeah, it's something.
Yeah, I think that when we listening to the group at the forum, one of the things that came up that I'm kind of hearing from you and Robert is that it's very little to do a whole lot, especially when it comes to often course correcting or finding a balance from the more directive style that we see in medicine in the United States.
Right. Yes, I think, I mean, what I can feel good about after their PGY 1 year is that most have had a pretty significant demonstrated increase in proficiency. That said, that reflects that they were able to do it in this unique setting at this time. So then the application in their own clinical skills becomes, once things get crazy and you're under super time pressures and stuff, that I think is our hardest domain. And so, we know they kind of have those skills. For them, what kind of becomes really important to them is, where can these skills help me out of sticky situations? That is what I find, is that, that's what drives interest in it over time, is more that, even than whether or not I was helpful with my patient from a change perspective. They don't actually know about that in the moment. Is that happening? But like helping with discord in particular, they're very, very open to those conversations, especially in their 2 and 3 year.
Yeah, they really want these interactions to go well, and they recognize what they're doing doesn't facilitate it when it doesn't go smoothly.
Yeah, that's when.
What about other folks who are doing training? What other models are people experiencing or reading?
Let me ask if it's okay if I make a group process suggestion, because I'm happy if not to interrupt the flow, but what I'm thinking, I'm just listening and watching the time. If you're open to this, there's a bunch of new people here, and I'm wondering if people would do a 2 or 3 minute, if this will fit with what you're thinking, me, just who you are, where you're teaching, and if you have any nuggets, I guess, of things that you want to share or ask about. And maybe then in 10 minutes, we could get a sense of who we're talking to, because I could see it's possible a few people are new here and we won't have heard from them at all. Is that okay, Mead? I don't want to take over your show.
It is. The reason I didn't do that is we did that in the beginning, but we could do it again since some new people have joined.
I missed it. I'm sorry. All right.
Would it be helpful for folks to do that again? Because we gathered a little bit, like we didn't all get to hear the great the stuff that everyone was bringing.
I apologize. I came late to the show.
Well, and you were helping get people to the show. So, well,
let me just at least say one thing, and that is since I didn't realize that I had missed the introductions, but on the website, which is fledgling and going to get there, because there are some new people here, and I don't want to lose you for the future if you're invested. I'm going to just show you one thing on the MIMed website, which if you haven't seen, it's there. There's one thing that I want to point out about it. It's MIMed www.org, and there is a place there, and I guess I was having trouble sharing it. Oh, there it is. Okay, so let me just share if it allows me to do this. So if you haven't seen this, please have a look and sign up for the mailing list, and because you'll be getting things, you can press here and get the mailing list. The MIMed stories will eventually have these recordings. Right now, George is the only one who's been posted, but this is where we're going to live. But in the Living Registry, you can click here and add your name to the registry, and it's called Living because we want a living registry of who's doing what in motivational interviewing and medicine, and there are about 60, 70 people. So I think that's the main thing that I wanted to say. You can make sure your name is on the mailing list. You can add your work to the Living Registry, and there'll be a way to get to it. There's reasons that it's not fully posted here, but you'll be able to write and ask for it. Or when you add your name, I send it to you. So I will close that down and turn it back to the group. And however you want to run. I'll say briefly about myself. My work has been cross medicine. I've been in interviewing like Robert wrote. And my hair is also as white and gray as yours. And I've been doing this for about 40 years. I'm a psychiatrist, and I've worked at many medical centers. I have been working on teaching in a way the same mission that MI does, but I started before I knew about MI. We developed something called the three-function approach. It's in its fourth edition. It's coming out in a few weeks. But what's happened is that after the book was written, Mead, you mentioned, Roy Stein, and he and I were working together, and so the three functions are connect, co-construct, and collaborate, and it overlaps with MI. So after about 20 years into this work, they suggested people who are using the textbook in medicine that I learn MI, which I did. And so there's a lot of MI in the book now. It's used in medicine. Terry Moyers has contributed a chapter. And I did specifically work on brief action planning, which is about the fourth process or task of MI. And I begin the MI education with brief action planning, which is a way to help people who are more ready to change. And then I enrich the teaching, if so to speak, once people have mastered the fourth process, if you will, brief action planning, it whets their appetite in medicine to learn to take a deeper dive into the richness of motivational interviewing. So brief action planning, for those of you who don't know, it is based on the principles and practice of MI. So that's what I've been doing in a bunch of medical centers, and I've presented this work at various MI forums. But I will turn it back to you, Mead.
Right. And I want to do a structural question. So I want to make sure I'm clear whether we are meeting for 30 or minutes or an hour. I
It was
heard
an hour meeting.
It's an hour.
Okay. All right. So to make sure, so I guess to come back, so your experience with this, you've done training as a psychiatrist, and then you have materials that you've developed that you're hoping and people have been using for training. And that's sort of the model that you've been working off of as well.
Well, I am a psychiatrist, but my work has been with general healthcare. So the three-function approach in 1980 was developed with internal medicine colleagues mostly. So, and actually, I find in psychiatry, there's been a lot less uptake I'm a psychiatrist, psychodynamically trained. I do family therapy. So I love psychotherapy. Um, but within psychiatry, actually, I'm actually trying to hopefully get this approach more accepted because in psychiatry there is a more tradition of interviewing that sees psychiatric interviewing as very specialized and different from medical. And I'm trying to carry the banner that a good medical interview is a good psychiatric interview, and transference happens in medicine and it happens in psychiatry as well. So my teaching experience, me, it has been in internal medicine and family medicine at Emory, at North Carolina, at Stony Brook, other medical centers. But I think in terms of bringing the strength of interviewing, I've mostly started with trying to do the more encapsulated things first, like brief action planning, which is a pathway into and through planning, and then expanding for people who are interested in taking a deeper dive.
Yeah. What about other people? We've got a couple of different models we're starting to hear about now of ways to integrate it. What are other people doing?
I can share a little bit. I might actually be the outlier to the group. My primary focus for the last 15 years in training motivational interviewing has been in the criminal justice setting. We've also trained behavioral health, child welfare, social services. And recently, last year, I trained a group of EMTs, which was a lot of fun. And so I have kind of like twofold purpose for being in this meeting today and trying to like get in the niche a little bit. One, we have a lot of crossover with criminal justice folks that are also involved in lots of mental health issues. They have lots of chronic disease, all of those kind of things that we also see and interpret and try to figure out and navigate. As well as I've been the primary caregiver for four family members who have gone through various levels of the medical field and sometimes at my horror. And because I am who I am, I usually step up and say something to the providers when they're, maybe not approaching something all that great. So have kind of noticed that maybe there's a need, at least in the state of Colorado, for some additional training. And I would love to kind of step into some of that space to see where I can lend some assistance or lend a hand. But the training that we do is typically, kind of like a 2-day intro and then a 2-day more advanced. And then we have communities of practice that people also participate in between the training so that they can continue to practice their learning. We also do taping, coaching, feedback. For the group of EMTs, I also provided kind of an intro, virtually self-paced, where they had some worksheets to complete and submit to me and turn those in. And then we came together for just the 2 days of more advanced and like what you learned online at your own pace. How then can we apply it when we came together for some more advanced training? So that's kind of what I've done and kind of why I was interested in this group. I tried to find you at the forum, but I couldn't ever find your group. So I was bummed out about that. But glad we can connect here.
Yeah, this is great. Yeah, so it sounds like part of in there, I think there's definitely connections with justice involved people and in part because of some of the things we're starting to hear is that there's a very specific style for interacting with people that is not always motivational interviewing consistent and culturally. And so how do you start doing training that has impact on culture of interaction? And you're doing that in two areas, and it sounds like you're integrating the mix of this sort of, I call it didactic, but it I'm sure includes, as other people have said, role plays and videos and things like that. And then
Yeah.
also that community of practice piece, which you also brought in, Ashley, of kind of talking about like how do you allow people to keep practicing and get feedback, since that is such a high impact training activity within these, again, cultures where it's not always fitting.
Yeah.
I can share really briefly to help Kara not feel like an outlier. So I'm Amanda in Washington State, and I train child welfare workers, but we're looking to do more what Kara is doing. So training for nursing staff, schools, first responders. Yeah, and so we do something very similar. We have 2-day foundations, 2-day advanced. We do community of practice learning groups, practice and feedback. We use the MICA, and our learners can provide recordings, and then they are to do one in-person field coding with their practitioner. So
And to check, so it sounds like for you, you're transitioning into working with nursing staff is the plan, or is that already part of your work?
that's the hope.
That's okay. So say okay.
Yeah, so I'm here to listen and learn.
Yeah. And it sounds like you have experience again with situations where people don't always listen well or struggle to listen well because there's such a external focus on a certain outcome, often one that's got a high level of discord.
Yes, absolutely.
Yeah.
Yes, and I appreciated, I think Ashley was the one that shared that. I hadn't thought of, because oftentimes child welfare workers don't feel like MI fits well with their work because they feel very focused on obtaining information, and it's very court-driven case plans, but maybe the way in is through the conversation about supporting Discord. So I appreciated that.
When you all think about what's working best with the challenges you're facing, whether it's a specific technique, a specific focus, I wonder what do you all find works best when you're trying to bring a new culture of interaction into these situations or these settings?
I think for me, I try to create as much as I can. I learn about where they're coming from, what their focus is, and then try to make examples specific to their work so that they have a connection. And so try to ground exercises, examples, those kind of things, and the work that they do day to day and the connection to the other pieces of the system.
Evoking from them, like that engagement and evoking steps in the 4 processes, and doing that with the people you're training with before you start doing anything else.
Yeah, and I think part of it too is a little bit of research on my part to kind of know, if I don't already, what exactly, their ins and outs and where their kind of pain points might be. That would be helpful to kind of like uncover how motivational interviewing may assist or help them.
Yeah, bringing in it's something I'm thinking also, some of my own experience working with the residents. It's both having almost being meta about it, right? If we're listening well and we're doing good MI, we listen well to the individual while we also have kind of the nomothetic or the sort of background of this is the zeitgeist of the experience they may be having. And I'm intentionally listening for certain things so it's a shift back and forth from knowledge that we have about the setting to the person and pulling it up. It's a lot of work. What about other people what are you finding works best as you bring these kind of trainings into your situations or settings?
Hi, it's Jennifer.
Hi.
Hi. I'm very new to coaching. I'm interning at Emory with Ashley and Asila and Rachel. I've noticed that it's helpful to acknowledge with the residents that they are coming from a very prescriptive lens, and emphasizing autonomy and almost reversing the prescriptive lens has been very helpful when we talk about that first and foremost.
So doing some of what motivational interviewing and good relational skills would do, which is that emphasizing autonomy, and then you said reversing the prescriptive lens. Could you talk a little bit more about that?
Well, I've noticed that the the impulse to have a solution, the writing reflex is very strong at first. And when we talk about emphasizing autonomy and affirming that the person that they're working with will know what level of change they're in, we'll start to develop and talk about answers that you can sort of tease out, and that is not necessarily the process that they're walking in the door with when we first start. our coaching.
Hmm.
Is that the expert in the room is their patient.
Hmm. So when you talk about flipping the lens, it's flipping the perception of who the expert is in the room so that they're not taking that one-up position from the start.
Exactly.
I wonder, and you or others, I wonder what exercises people do experientially to connect people to that. Because it's a really different perspective.
I can share a exercise which is a lot of fun, but it does take a certain amount of time. So if you have a group of like 30 or 40 or more, you take the back half of the room, send them outside, close the doors. Hopefully they don't hear what you're saying on the inside, so you might have to unmic yourself. You tell the people left on the inside of the room, when I open the doors, those people outside are going to have their eyes closed, and you can do whatever you think will be helpful to get them back to their seats. Okay? And I may have said this wrong. You want the people sitting in front to go outside, because the people in back will have seen where they're sitting. All right? So you tell the people inside the room, help these people get back to their seats safely. You don't tell them anything else. You go outside and you tell that group, you're going to go into the room with your eyes closed. You need to get back to your seat somehow safely. So that's all you tell them. What typically happens, of course, is the inside group is intending to be very helpful, prescriptive, directive. They line up and they grab somebody that's coming in because they might recognize them and where they were sitting, and they will guide them to their seat. The people that were outside already had a plan. They already came up with a plan about how they were going to get to their seats. And of course, then you talk about that, and it highlights that the people that you thought were blind and incapable, they were going to find their seats if you didn't do anything. It's a lot of fun.
Yeah, that sounds great. Do you, I love that's such a nice physical way to have people engage in that knowing and unknowing. How long does the exercise take?
Well, it takes probably about 20 to 30 minutes, because you got to get half the group outside. You got to give instructions to one group. That's 5 minutes. And you got to get instructions to the other group. That's 5 minutes. Both groups have to have time to plan. And then another 5, 10 minutes to open the doors and let people come in and chaos to occur. So it's a nice, it's got multiple points. One is these people that have their eyes closed are capable. And two, it's an energizer, breaks up the hearing me talk.
Yeah, it sounds like an excellent exercise. Like it's a really creative way to flip those positions in a way that anyone from any background can experience.
I'm sure it's not mine. I'm sure somebody else authored it, so don't attribute it to me.
Thanks for sharing that exercise. I really like it. Now I'm thinking of ways to apply it to Zoom.
I wonder what is most challenging for people when you're working, again, and we're talking primarily about medical settings, and I think as has come up, settings where the relational skills and motivational interviewing is something culturally a bit different. And I think we brought up some of them, which are one, how can doing something different connect to goals, like managing Discord, like getting information, like efficiently doing one's job in a way that is often lower energy than, for example, arguing with people or trying to just give advice might be, as well as I think engaging diverse groups. There are other things that come up for people.
I think maybe for me, it's also about helping people slow down, maybe read the room, see where like the person is at that you're actually attempting to work with, whether that's a patient, whether that's a family member, whatever that scenario is. I think sometimes us as practitioners, we think we have all of the answers. We think we have the best ways to help people, and that may not fit with what that person is currently experiencing. So I think one of my biggest focuses is just really try to get people both in criminal justice and in the social services world to kind of just slow down for a minute, read the room, and then adjust yourself before you ask somebody else to adjust.
And how to address that time trap. Yeah.
Could I just, I suppose, I don't want to take things off on too much of a tangent, but I was asked recently to work with I work for the health service in social inclusion in the addiction services, and got a wide variety of medical colleagues, psychiatry, nursing, GPs, and in one of our departments, a colleague has asked for some training in MI for working with communities that are responding negatively to migrants and refugees with prejudice and all of the kind of stuff that's going on in social media. So he's asked to train his team in MI, and I suppose one of my initial responses was that you can't really use MI to get people to do what they don't want to do. But in terms of a kind of a communication style, if you're going to engage with people that hold those kind of prejudicial and stigmatizing views of new communities, MI might be the style to choose in terms of how you communicate with them. So I'm just kind of exploring the potential for that training to address that particular issue. And if anybody had any thoughts on that or know of any other research on it or anything that might help to shape that training into the future.
Yeah. I might be able to both offer and also a little bit of an answer of my own question about what's most challenging and what something I moved into a little bit unknowingly, which is always the best way to fall into something good. But when I started teaching residents in June, so I'd never done this work before. I'd primarily done clinical work, with training being the fun extra thing I got to do as part of my being a clinician. And so now it's full-time training and working with the residents. I just read Effective Psychotherapists by Bill Miller and Terry Moyers, and thought, great, these are such essential skills to interacting with people. And I ended up, my first 4 months of training the residents has not really been training motivational interviewing. It's been training motivation or relational skills. And they keep asking when motivational interviews come in. I'm saying this is, and I scored them with the Mighty, but just focus on scored recorded tapes with the Mighty, but just focus on the relational skills. And it's hard for them to hit that. And I kind of share, if you can't do this, you can't do the technical skills. Like they're part and parcel. And I wonder about that for your question, Robert, of can you train people to be good listeners and in good listening, there's space for hearing, and for shifting and understanding. And I think and someone can help me with this, hopefully, there's a study they did, and I cannot remember what they were trying to convince people to do, but they were going door to door, using motivational interviewing to try and convince people to leave, immigrants to leave. And they trained all the people in motivational interviewing, and then everyone felt incredibly uncomfortable, and it didn't really work, because to your point, you can't convince people to use motivational interviewing to convince people to do what they don't want to do at all. So that, I don't know if anyone knows that study. I could probably find it for you. I have it written down somewhere if you want me to send it to you, if you need data to help communicate. But yeah.
Yeah, in our discussions, we actually discussed that. I think it's in the fourth edition. Bill or Steve refers to it in the fourth edition, where nobody actually left the country who was there illegally, I think. But I suppose what we're interested in exploring the potential of is the discrepancy between how people in these communities are reacting, or kind of reacting to refugees and migrants, because a lot of them are kind of living in the same communities we do, and are raising families, and probably have hopes and aspirations for themselves and their loved ones, and probably have a lot of similar values as the rest of us in the community do. And just the potential for exploring the discrepancy between their own values and how they're reacting to these new members of the community. I thought there might be that where MI might fit, if you like.
I can share one thing that I have done. I have no idea if it worked because I collected no data, but I collected a bunch of pictures and videos of what you would call or search for as unlikely friends. And these are all animal videos. Mm-hmm. So there's a video story about a dog that went by this one house where a cat was. The cat would come to the fence, the cat would jump down, and off they'd go on a walk. And the dog and the cat guardian didn't know each other. The dog and the cat did this on their own. You may or may not be aware of, there's another story which has a full-length documentary of a couple in England who bought a baby lion from Lloyd's of London, raised it in London, and then arranged to return it to Africa because, of course, it got to be 400 pounds. And taking it to the park to play involved getting everybody else out of the park. So they were successful in taking this lion back to Africa, and some 7 years later they went back, and they have a video of this lion with its pride coming down off the mountain, running up to these fellows and hugging them. So I thought, and of course I may have been the only one that got anything out of this, I thought it was a way to sidestep all the rhetoric and say, look, these are species, animals that don't typically get along. And yet here it is. There's another story about a dog and an elephant that became friends. And when the dog was injured, the elephant stood for like a month outside the house, and they brought the dog down. The dog had been injured and couldn't move, and they brought the dog down to see the elephant. And of course, once the dog got better, they were pals again. So there's a bunch of these stories that I would play as an attempt to sidestep the usual rhetoric and maybe raise, if I could get away with this language, subconsciously, the possibility that you're not that different.
Thanks, Robert.
Well, I am noticing it's about 3 minutes till 2. And just to kind of, I guess, go over some of the things we've talked about today and figure out next steps for everyone, or to invite people to think about their own next steps. That we did some introductions and we had a nice diverse group. When people talked about some of the examples of training for medical staff and for other people in other environments where, again, you're bringing us somewhat of a culture shift in, ideally there's some community of practice and some long-term, and that's not always the opportunity. And that's also one of the challenges. Um, the and bye, Sela. Thank you for joining. And then we talked a bit about that there is some clear change. You brought up that as an example, Ashley, that even with some of fairly short amount of training, you can do some follow-up in 2 or 3 years and see some effect of what the training was. But how do you maintain that? And then some of what is working best is doing some of the evoking and engaging that are the essential processes, but doing that, again, doing a parallel process with the people that you're working with to help them being interested in focusing on changing how they interact with patients or other people. And then we had some other interesting examples, which, like, for example, you brought up, Robert, of like, how else could this fit and how do we use it to facilitate culture? So I can almost culture shift. So thanks everyone for your what you offered. It's a real treasure to hear, I think, from everyone what they do and their perspectives.